You're all having a great afternoon. We have folks just another minute to join us. And then we'll get started. Welcome again, everybody. We haven't had anyone new join, so we'll go ahead and get started. So again, good afternoon and welcome to today's Pediatric Readiness Recognition Programs collaborative session. This is our 8th session, and we'll be picking up from where we left off back in April. And before we get started, today's session, we would like to acknowledge that the Pediatric Pandemic Network and the EMS for Children Innovation and Improvement Center is supported by the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. And as a reminder, today's session is going to be recorded and posted on the EIC's website, along with today's presentation. And as always, we look forward to having an interactive session with you. Also, please feel free to raise your hand or come off mute throughout the presentation. And during today's session, we are going to continue our discussion around recommended minimum criteria for both the pre-hospital and emergency department pediatric readiness recognition programs. We are going to wrap up our discussion on the application process and then begin discussing verification process while hearing from Nicolena Mitchell and Sam Vance. Looking forward to that. To start us off in discussing the recommended minimum criteria for emergency departments, we'll be hearing from Dr. Kate Remick. Welcome. Doesn't look like we can hear you, Kate.
Apologies for that. Good afternoon, everybody, and welcome back. I hope everyone had a great time. For those of you who went to the PEC meeting, and let's dive in. Casey, with the next slide on just kind of where we have landed so far. So as you all know, we have gone through this modified Delphi process of looking at all the components within the Pediatric Readiness Joint Policy Statement Guidelines, just kind of a broad sweep. And went through a process of evaluating those based on national quality form criteria of importance, scientific acceptability, feasibility to measure, and then lastly, usability. And where we've found ourselves landing is on these really 6 components of the minimum criteria. So the first related to administration and coordination being the appointment of the PEC. The second under policies and procedures, having the inclusion of pediatrics within policies and procedures, and we'll maybe talk a little bit more about that over time, but this is very kind of broad sweeping and non-specific. So it would allow for a lot of flexibility in terms of how a site met that. The third being the inclusion of pediatric considerations within the disaster plan. The fourth being weighing children in kilos, and you'll remember we had a lot of robust discussion about weighing versus weighing and recording and the challenges of getting EHRs to really only present weight in kilos, and felt that within scope of practice, the easiest first step was weighing in kilos, not necessarily recording only in kilos. And then looking at equipment, supplies, and medications, the 2 items that were really identified were access to a weight-based pediatric resuscitation cart or equipment, and then last, having all of the other recommended supplies and equipment that would be readily available. The group did not identify specific care team competencies nor QI, PI that they felt should be within the minimum criteria. All other items were kind of shifted over to stretch criteria, and you'll see those listed in the right-hand column. So what I hoped we could do is just spend a few minutes talking about these minimum criteria. And really talking, I guess, more specifically about how they might be implemented within your recognition programs. If you could go to the next slide, please, Casey. And I know this will be discussed a little bit later by Sam and Nicolena. But I thought it would be good just to kind of provide a high-level overview of what might be meant by this. So if you have a PEC, how would you assess that? In some cases, it might be as simple as just saying, do you have someone who serves in this role? Yes or no? And who is that person? And list names, credentials. You might ask if they have a job description. You might actually ask them to be present during any kind of verification visit, whether it's virtual or in person. And you might find out during that visit in conversation what they do. And whether they have any protected time to do that work or how they kind of fit it into their schedule. So that's kind of generally speaking what we're talking about when we're talking about a minimum criteria. How would you go about assessing that? The next two items around policies and procedures and or inclusion of PEDS and disaster plans, the way that you might go about assessing this minimum criteria is within the application, ask them to check off which of a list of policies that are perhaps listed within the PEDS Ready guidelines have the inclusion of pediatric specific needs. So they could, for example, just check off, yes, we have this policy, this policy, this policy, etc. You could ask them to actually submit those policies if you wanted to make sure that they actually have them and that they actually exist. You could potentially during your site visit actually go and review that policy, look at them and say, hey, could you share with me the policy on pediatric triage so that we can take a look at that? And can you walk me through the process or describe that process? So those are ways of kind of assessing the inclusion of pediatrics in policies or procedures. It's just kind of asking about it, hearing about it with the leaders from that site. Weighing children in kilos, again, it can be a simple question. Do you or do you not? You can ask them simply in their application, do you weigh children in kilos only? If they say yes, then during that verification visit, you could potentially walk through their triage area, look at their scale, say, now, how do you lock it? How do you ensure this is in kilos only? You could check the scale and you could ask about their process. So how do you ensure that it doesn't get flipped back to pounds, or how do you ensure that kilos only are used? So those are just ways of kind of assessing this. And then the last two items, and this is one that, you know, I'm so excited that everybody really felt that this was important, and certainly I think we all believe it is, but asking about whether or not they have a pediatric resuscitation card and whether it's color or weight coded. And during those verification visits, similarly to the other things, sometimes it's just walking through the resuscitation bays or walking through the emergency department, or you can do it virtually, right? FaceTime or with an iPad through Zoom or something like that. And you can actually have them show you, okay, here's where the resuscitation card is, here's how it's set up. You can ask them about what items are included in that so that you know. And then the same is true with equipment and supplies. So I wanted to share this just so that folks had an understanding of, you know, how you might go about assessing these things within an emergency department. So I just want to pause and see if there's any comments, questions, other ways that people have done it. Would love to hear. You'll hear a little bit more from Nicolena and Sam in a few minutes, but any other thoughts about this? Does it make sense, hopefully? Okay, y'all are going to be a quiet bunch today. Okay, the next thing though, I want to go to the next slide because I really want to ask you all to possibly reconsider having a QI plan. And the reason I want to ask that you all reconsider this is that it is notably one of the two primary drivers of pediatric care and pediatric readiness. And we know this from the assessment. It's associated with an average adjusted 26-point increase in weighted pediatric readiness scores. And as you've heard before, I think one of the things that we know is critical is this achievable? Well, 50% of EDs reported having a quality improvement plan. And so it's pretty readily available. Certainly, I think we all know that 50% of EDs are probably not pediatric ready, but yet 50% have a pediatric QI plan. And if you look at the work that's been done by trauma centers, stroke centers, STEMI centers, they're all really grounded in quality improvement. This was something that we ranked fairly highly. We actually gave this a score of 4.2, I believe, Casey, you can chime in. 4.1, 4.2?
I think it was a 4.1.
4.1. So it wasn't rated lowly, but I think where people are maybe struggling is like, what's it required for a quality improvement plan? And I would say that when we talk about QI, we're not talking about a specific threshold. And for the most part, we're not even talking about a requirement of tracking specific measures, nor does it require technology. In fact, most EDs that report having a quality improvement plan, all they're doing is a simple chart review. And I would say at bare minimum, a quality improvement plan is saying, should all EDs review the deaths of pediatric patients in their ED? Should that be a requirement? And if the answer is yes, then that is a QI plan. It might not be a robust one, but it is a quality improvement plan. And it's the only way that they can make improvements. So I just wanted to share this, and hopefully people have thoughts or comments, but I really do feel strongly that this should be part of our minimum criteria because it's the only way that we're actually going to improve. But I just want to open the floor.
Kate, may I say something real quick? And then Mark, I see you have your hand up. Mark, are you okay if I make a quick point?
Of course.
Thank you. I see where there is a little bit of angst around this because in our own Colorado work, and Nicolena might kind of hone in on this later a little bit, this comes up regularly as well, what should we look at? How should we do this? However, to the point that you made, what we have found among some of the hospitals is that although this is the biggest hurdle they have faced, it's also the one that has really gotten the full court press readiness on board at the facility. In other words, when they decide they're going to pick a measure and they start looking at that measure, it really engages at the entire hospital level work to do this. And that has really empowered people to be very directly involved and engaged. So there's a lot of trickle down benefits to this, by including this as an important measure.
Go ahead, Mark. You had your hand up first. Thanks, Kathleen. Thanks for that.
Thank you. Good afternoon to everyone. I was just going to say I'm very supportive of the idea of having some metrics for a QA or QI plan. And I talked with at a recent perinatal quality meeting for our state about this very aspect. And one of the issues that came up from hospitals is when we look at it from a QA perspective of doing chart review of that is onerous in the sense of what are they looking at, what benefit are they going to do? And I wonder if there's opportunity rather than trying to eat the whole elephant is to define either through a state or regional metric some of the things that could be looked at specifically for improvement areas so that they have some guidance of what to look at and tools to do so. And I also think about that from an umbrella QI perspective of aspects that we're looking at, or perhaps examples of QI plans that emergency departments have used. And I'm not thinking, here in New England, we always jump to like Boston Children's, and their QI program may be expansive and impossible for a critical access ED to be able to achieve. So I think the idea of the QI plan from the user perspective of a hospital ED is that it's too much to take on, and they would rather have some guidance of how could we do this in little bits. And if they feel successful in those little bits, they may expand that internally to say, hey, we also want to look at, in addition to X, we want to look at Y. But if we gave them a starting place, I think about the Always Ready for Children program that we have up here on the Eastern Coast, where we have a multitude of states involved in this, where we could look at something specifically within that in those areas and maybe get some detailed and valid data on one piece of information as opposed to all of the information. Just a thought, but I'm supportive of adding it. Thanks.
Yeah, thanks for that, Mark. And yeah, I think that's the question. I think when people hear QI, they always jump to kind of the upper ends of this arrow, but it doesn't have to be quite so robust. But Nicolena, you have your hand up, so please go ahead.
Yeah, and I mimic what Kathleen and Mark say, because our first hospital that we met with to verify as pediatric ready in our state was a, level 4 facility, who, when their QI team met with us during their verification process, they said, we QI sepsis, and that's 5% of our total patient population. And to not review 20% of our total patient population made no sense to why we weren't doing it. And so from that perspective, when they looked at it from their numbers, they said, okay, yeah, this makes a lot of sense. This is something that we should do. And I'm just going to share my screen real quick, if someone would give me the ability to do so.
I think Casey will. Nicolena, give her just a second.
To Mark's point, our QI requirements for our hospital verification program, and we refer to it as COPPER, the Colorado Pediatric Preparedness for the ER. Hopefully you're seeing the EMS for Children Colorado website. So we have 2 levels of verification in our state. And for our QI portion, we say that all hospitals must have a QI plan in place that looks at the weight in kilograms, recording weight in kilograms, and weight-based medication dosing. All facilities who want to participate also must review, and this is the minimum requirement, all pediatric deaths in the ER, all critical transfer cares out, and at least 10% of the patients, 10 patients per month, or 25% of all of the pediatric admissions. And then if they want to become the higher level, you can look at those 2 criteria in the middle. That has given our facilities a really great base to start from. And we have seen great expansion from those areas. And I'll drop that page in the chat so you guys can to look at that later. We have seen great expansion from that, using that as the base platform for which they can start. And then, so for example, one of our facilities said, we decided to use a criteria to look at all of our patients that we discharged home, because I apologize for the background noise. I'm at a big public meeting today. They said, let's look at our patients that we discharged home, because we're missing some patients and they're bouncing back. They looked at IV starts. And so that baseline really helped them expand up. And giving them that framework to start from really helped.
That's awesome, Nicolena. Thanks for sharing that. I love seeing how you started it. So you started with review pediatric deaths, review critical transfers, 10 patients per month. So really, I think something that's a little bit tangible or digestible. Are there other comments or thoughts? Anyone who's in opposition to this or feels like it's just too big of an ask?
I think part of this is that people get freaked out by just hearing quality improvement program. I think if we just focused on, okay, these are the things that can really help you, do a better job in pediatrics. I think, part of this is really plain language and making it less intimidating.
So if we created some sample language like Nicolena has, or borrowed from each other, that maybe this would be an appropriate start. Go ahead, Mark.
Oh, I was also just, as Nicolena was talking, I was thinking about some of the stuff we do and whether this would meet any of the criteria. I know here in Maine, and I suspect a lot of other states and territories as well, do QI based on their trauma advisory committees or trauma boards, whatever they might have. And, those are pretty nuanced. In Maine, we recently looked at pediatric injuries around wood stoves and kids falling into them. That's not going to be a great metric if you're in Florida. But, do you think that those kind of aspects meet that criteria, and how could those be incorporated in, if so? The idea of, a hospital says, well, we don't have necessarily an internal plan, but we participate in statewide initiatives or trauma initiatives or sepsis or cardiac initiatives. They do cardiac outcome with cares and things like that. Would that fall into some of the aspects of QI, and may they already be meeting some of that?
Yeah, I think that's what Emily put in the chat, is integration of pediatrics into the overarching QI plan as opposed to creating a completely separate one. And, I think this is up in large part for you all to decide if it would be acceptable based on your state's criteria. But I think just the conceptual framework of having some kind of quality improvement that integrates the needs of children would be of value. So Mark, I would say, yeah, if the hospital's participating in cares and is looking at their performance, and it includes pediatric performance, then that would certainly be quality improvement. Or burns and management, etc. But Cindy, you had your hand up.
Maybe it's more of just describe what QI initiatives you do in your hospital, as opposed to here's what you have to do from us.
Yeah, you could absolutely start with that. Yeah.
I mean, most hospitals look at sepsis in adult world. Just if you have kids that come in with sepsis, are you meeting like time to antibiotics, time to fluids?
Well, I mean, I think that's a good point that Michelle has brought up. I mean, there are specific things that Joint Commission requires you to do in every hospital QI program. And by, if people, attach a pediatric component to that, that is major. And the reason it's major is because then it becomes transparent and visible to Joint Commission. And when that data is available, then it creates the opportunity for better buy-in, from the C-suite and the organization as a whole.
Thanks for that, Pat. That's a really important point. Cindy, you had your hand up.
Yes, and for full disclosure, I cannot see the screens because I am commuting back from a convention. But the feedback we got in April when we met with, I believe, 35 of 49 of our hospitals was a concern that we might take it to a registry level, because we have a trauma registry, a burn registry, a stroke registry. All the perinatal centers have to do Vermont, Oxford. And when Dr. Jen Anders and I reassured them that what we were looking for was that they look, and we have a CARES registry for cardiac arrest that all the hospitals by law have to give us outcomes for. And when we pointed out that what we're looking at is that a dedicated 2 people at the basic level and a committee at the resource level look at the pediatric cares data, look at a specific set of metrics they identify and work within their region, but that we were not talking a new software that would cost thousands of dollars a year for their corporation. There was sort of a deep sigh of relief that we were talking more than quality assurance, but trending, and that we weren't going to add one more, because I think it would be a 6th registry that our own agency requires of hospitals. There was a lot more buy-in to look at death, look at weight, look at bounce back, those types of things. So I would suggest that you look at whether it's from a national organization, if you use the college or Vermont Oxford, or your state, what are you already asking every ED to do on how many different kinds of patients, and just ask them to identify which of those they're going to focus on for pediatrics for a period. And they suggested 18 months. We haven't decided what that period will be.
So with this, I mean, what I'm hearing is a lot of support from people who have spoken that if we are provide great latitude in what the QI efforts are, if we suggest that you should be doing something in terms of looking at how care is being delivered to children, integrating it into what you're already doing, describe it for us, tell us about it, and maybe provide some examples.
Kate, I think it could be reframed as that you are already looking at, you're already doing things. It's just that they don't look at the pediatric data as part of sepsis and, their morbidity and mortality committees and, those kinds of, or their code review committees. And you need a group of people who are willing to take a special look at that pediatric data component and work with the quality people to get those reports built into the med rec, because you should be looking at it, and depending on the resources in the hospitals that are available, I mean, many of these quality metrics are on dashboards. It's just that the pediatric part is not being broken out separately.
Okay.
They're on internal operational bed dashboards. And the C-suite people are watching that all the time, because that goes to the hospital's ranking, and it goes to CMS, it goes to reimbursement consequences, as well as the Joint Commission stuff. There are lots of places where hospitals are being held accountable, and we need to, have people, a group of people taking a look at what is the pediatric component in your hospital, and what does that look like? And just doing that would be huge.
Yeah, right. That would be a huge step forward, and it would help ensure the results that we're actually here to make sure occur, which is to improve care for children. Kathleen, you have your hand up.
Yeah, not to belabor it, but I think what you were saying and kind of to come back around would maybe be a bit of a laundry list of what counts for this. So are you an ACS center? If you are, you need to, it's required to be, to put in a pediatric improvement plan, for your ACS thing. Is there something you're doing through the Joint Commission that includes children? Are you a critical access hospital without a lot of resources to do this? One option is the NPRQI. Like, I think a list of ways that people could meet that criteria would be, I think, very helpful. And then based on what item they choose, then a list of resources to help them do that specific thing. I think you came and met with our copper group in Colorado, which was, I think, really helpful to speak about NPRQI, because for some who are not already bound by being a stroke center or a trauma center, or some other, regulatory body within a state or nationally, it may be that they're on paper charts still, literally, and they don't have, they can't just pull things out of an EHR in the way that other bigger facilities can. So the NPRQI is a nice, kind of packaged way to do that. So I think, things that would quote count and as guidance, and then resources to do that thing that they choose to do, or that they're going to use as meeting that metric.
Yeah, and I'm not sure, in these other, community hospitals that, the day-to-day staff working in the emergency department, who are absolutely essential to participating in this process, really know all the quality stuff in the hospitals. They don't have conversations with the quality improvement coordinator in general every single day, unless they're pursuing some sort of objective in terms of like a stroke center or their trauma center or that kind of thing. I think the hospitals can do an excellent job in incorporating they need to know what they already do before they create more work for themselves. I guess that's what I'm trying to say.
Yeah, and Evelyn, to your point with benchmarking, that's exactly what NPRQI does, is benchmarking. So thanks for sharing that too, Mark, and thanks for all of these comments. I mean, do you all feel like that? I feel very strongly that this is critical, because if we're not doing improvement, where are we going to go? But I'm not hearing opposition. But Dwayne, please, do you have comments?
So I apologize, I missed the first 5 minutes because of a personal technical issue, but I guess I'm hearing that the quality improvement piece of it was not part of the minimum standards that made the list. And
Correct. Yeah.
although personally, I believe quality improvement is very important, and I don't disagree with anything that's been said here, I gotta feel that there's something within the respondents that feels differently as a group, and maybe, and these are my own words, that this is a strongly encouraged or highly recommended, supplement to the list, but it didn't make the list as the way the process was designed. That's just my thoughts.
Yeah, in the second round, it was up in the top, and in the third round, I think it was 4.1. So it wasn't super low, but I guess anyone who maybe had ranked it low and had concerns early on, I would love to hear your thoughts of why you had concerns, or if those have been addressed. But Michael, go ahead.
Thanks, everybody.
We can't hear you very well, Michael. Yes, difficult connection. Janine, do you want to speak up about, do you think that this would work? Do you want to speak to your comment in the chat?
Yeah, I can speak to it. I think that having a minimum QI requirement should be there. Part of this is improving how we take care of our patients, and that process improvement starts with QI. You need to know where you're at and where your gaps are to identify where to make improvements. So I think, a QI component is important, whether we give them a list of suggestions of places to start, or we have a minimum of looking at those sickest patients, your deaths and your critical transfers admits. Is a good place to start. And then that helps you identify gaps and helps you figure out where your other QI components will be and where you should start your process improvement plans.
Thanks for that, Janine. I think just to speak, Dwayne, to your concerns, I'm wondering if maybe some of the reasons people scored this lower, some people did. A lot of people scored it high because it was above 4. But I wonder if they felt that we were asking for measures, or that we're asking that the plan be completely separate from what they're already doing. And so I'm hopeful in this discussion, it sounds like maybe we would be addressing those concerns if we provided examples, or said just integrating pediatrics into your current processes and practices already, or starting very small with, simply reviewing pediatric deaths and or transfers, or something that's easy to bite off. Rachel, go ahead, please.
I guess I'm just wondering, again, like Dwayne is saying, I'm not saying QI is not important, but we were all asked to participate in this process and to rank things according to what we know works for us or for our state. And now I feel like we're being asked to do something that the majority did not rank as being part of the minimum requirement. And that feels like it's working against the entire process that's been set up. So I would just ask that you would maybe honor what the majority is saying, and not people that are just interested in quality improvement.
Rachel, I'm going to speak up about that. And I think that issue will come up again when we talk about the pre-hospital criteria. But the group wasn't pulled together to say what works for you in your state. The group was pulled together to speak to what is important in pediatric readiness and what are aspirational elements, and then to take the criteria and then bring it back to your state and work it into your state in a feasible manner. So it's not purely just, you know, we're asked to vote on something that works for us. We're asked to take evidence, take the rationale, take the knowledge about what is important in pediatric readiness, and create a set of criteria as a collaborative that people feel like would be valuable and meaningful in creating pediatric readiness criteria for hospitals. It's not to say that you have a set of criteria that maybe a couple things don't work in Oregon and you take them out for Oregon. You absolutely can. But to set a bar very low doesn't support anyone. And so that was really the goal of the collaborative.
I think that
I just don't feel like you're listening. I'm sorry. I don't like you're hearing us. I know you have a specific job to do, and we know this, but I really need you to hear what we're saying and what others who aren't speaking up might be thinking. I need you to honor that.
Yeah, so I guess, Rachel, the reason that this is coming up is not to try to like force the group in one direction, but I am worried that people voted on this because they thought it was something that was really difficult to achieve. And I'm just trying to make sure that there was a shared understanding of what is intended in the baseline. It's just hard to believe that one element that's associated with an adjusted 26-point increase in pediatric readiness would not be part of our criteria for pediatric recognition. And that's, I think, why I wanted to bring this up. It was not scored low. It was not like it was scored below 4. It was actually scored high. And in the second round, it was in the top 5. I do think that people were maybe afraid of what it meant. So the reason that we were bringing it up again was to really come to a shared understanding of what it meant so that there wasn't confusion, that we weren't saying you need to track measures, or we weren't asking for advanced QI plan. We were just saying any QI plan. And the fact that 50% of emergency departments across the country have it is just suggestive that maybe it's not as hard as we think it is to achieve. Otherwise, 50% of EDs wouldn't say, yeah, I've got a QI plan that includes pediatrics. So, I mean, if the group feels that it's too hard, then, you know, got it. It's just unfortunate because it's so impactful for saving children's lives. So that's why we're bringing it up.
And this is Michelle. I think we have to also look at the evidence to what supports improved pediatric readiness across the United States. And this is one of those that is really makes a huge impact on that by just doing some minor things like looking at your pediatric deaths.
This is Phyllis Hendry. Could we agree on just some different verbiage, you know, where it's not have pediatric QI plan, but have pediatrics incorporated into the ED QI plan?
Yeah, I think that's what I'm hearing, Phyllis.
Yeah.
We just say, we change the verbiage and say, having pediatrics incorporated in some kind of QI plan or process that could include looking at sepsis in all patients, not just adults, looking at deaths in all patients, not just adults, looking at cares, you know, et cetera, et cetera, et cetera, could provide a long list of ways.
Yeah, I think again, you know, I think that's a really, really good point that was just shared. You know, we have, the more we make this separate, you know, like pediatrics is separate, the less likely we're going to get sustainable buy-in, because we've been doing that for a long, long time. And that hasn't really worked for us, unless you're in a pediatric center or, you have the resources in your state to, have that as a huge priority. But in general, most hospitals, this is about, just starting from the place of inclusion and not necessarily, and not mixing it up with a separate, effort that isn't included in quality, the hospital's overall quality program. The biggest win would be to get pediatrics part of an overall hospital quality program. That would be the biggest win.
May I just follow up, and Dwayne, I know you have your hand up, but to Rachel, to your point, and I don't want you to feel not heard either, but I'd like to have an understanding of, is there anxiety among the group that if there's a set of criteria that there's, consensus based on the evidence and importance, but it's not going to work for your state? Is there fear or anxiety among the state partnership program managers that they will fail to do the right thing when they, by removing some of these criteria when they create their own program? I just want to have a better understanding of that, because I think this gets at kind of the collaborative as a whole, and some of the other work, and is broader than just the QI piece a little bit.
So I just see in response to your comment, Kathleen, maybe I see a comment from Jessica to understand how to go about QA. I've never heard of an ED not knowing how to review a death. If you started at the lowest end of the curve, we could certainly have collaboratives. We actually do have an EIC-led collaborative that is for quality improvements, the Peds Ready Quality Collaborative. And it does teach them how to actually look at pediatric indicators and track those and drive improvements over time. But I think what the group is talking about is not something nearly that advanced. We're talking about some beginner steps of just incorporating pediatrics into an overarching quality improvement plan, as opposed to tracking pediatric indicators and making improvements based on that. And Morgan, I see your comment. There's concern that HRSA won't recognize a program if it doesn't include all of the minimum standards. I certainly can't speak for HRSA. They have set their minimum standards in the performance measures manual. This is really us trying to get towards a unified standard that is discriminating and ensuring that parents take their kids to the most appropriate facility. So I think that's where we were, in this collaborative. But Dwayne, please go ahead.
So I guess I go back to, I think, and many of us here have said that QI is important. I think there's two separate conversations. One is the importance of quality improvement, which has been identified with improved scores, to a level that's pretty significant. And verbally, the feedback from those that are on the call made the statements here. And the other is the process and where that value of minimum standards was set and where the value of the importance of quality improvement fell below that, put it outside the minimum standards. To me, I look at the performance measure manual and I see that HRSA says you must have a formal pediatric quality improvement and monitoring program. It's very general, and a lot of the conversation we've had in our state with our steering committee, of which have representatives from, some significant components, including our trauma program, who establishes their own standards. So they're doing what ACS does, but in Pennsylvania. So they've gone through some of these language pieces and helped us with putting the right context in the standard that we're developing so that we don't pigeonhole the program, but we don't miss something that we're trying to acquire in the way of a component. So, to me, it's important. It's in our program, it's in our state. And I think it almost, if we're going to speak to consensus, we've got to allow the states to incorporate it into their programs as they feel necessary, unless you change that value of what was a minimum standard to adjust it so that quality improvement is included in the minimum standards versus excluded. Just my take on it.
So we tried to settle on a limited number of elements so that it didn't feel overwhelming in the minimum standards. And, the lines fell where they fell. And I do think there was a lot of confusion around this particular one as based on the discussion, where some people felt that this was asking for pediatric indicators. Some people thought this was asking specifically for a completely separate plan. I guess my question to the group is this something that we want to revisit with a vote? Or does the group feel that we should leave it as is and walk away? And so I guess I'm wondering if we can at least take a vote to decide whether we feel like it would be important to revote on QI or not. And if the group says we don't want to revote on quality improvement, we want to leave it out, then so be it, I guess. Does that seem fair? Can we vote on whether or not we should reconsider this? Vote to reconsider. And that doesn't mean that you're voting yes or no today. What we would do is send a follow-up to you all so that you can feel like it's getting, but this would just be a vote to reconsider. I'm seeing a lot of people say, yes, let's vote to at least reconsider it or not. Seems fair. I haven't seen a no, so yeah. Okay. I mean, we had 49 people on the call. I think this is very representative. So if we can, Casey, can we vote to create a poll that we're voting yes to reconsider QI as part of minimum criteria or no to leave it as is?
All right, so the question is, would you like to reconsider the inclusion of pediatric QI plans as recommended minimum criteria, yes or no?
Yeah, I mean, it would not, we need to change the verbiage.
Okay.
But that can come out later, but it would be the inclusion of pediatrics in QI plans.
All right.
I'm seeing a poll on my screen, but I thought you just said you were going to be sending this out to all of us afterwards as a
This is
vote.
just a vote to reconsider. This is not a vote for approval in the minimum criteria.
Okay.
So this is just asking if the group is okay with moving forward with a revote on quality.
Well,
It's a pre-vote. It's a vote before the vote.
I'm asking that because I'm seeing a lot of people on this call that aren't EMSC program managers. Are they, is their thought and are they part of this vote? Because I
I'm
understand.
not voting, Rachel.
That's fine. I'm just asking for clarification because many of them said yes to a vote, but I don't even know who these people are.
There are other members who are part of EMSC State Partnership Program Managers teams that are joining the collaborative sessions.
So
Okay.
anyone who's not an EMSC manager should not be voting. Not everyone.
About 7 additional people if they're okay. All right, I think that is the end of the poll. Last call. And you should be able to see the results.
So we'll work on rewording and I guess send it back out after this meeting for you all to discuss with your states and come back with a decision on this. And the rewording will be incorporation of pediatrics in the overarching quality improvement activities. And this could include with suggestions, I think is what we heard from the group. And then folks can vote on that. I don't think there was anything else on these slides, Casey.
All right. Well, I think we appreciate your time and attention to that matter, and we'll follow up with you more to come on that. In interest of time, we will also continue the pre-hospital discussion during next month's meeting. So I do want to go ahead and hand it over to Julie then to wrap up our application discussion and begin discussing verification.
Hi, everybody. So to wrap up the discussion around the application process, if you remember back in April, we had Evelyn and Morgan, and we had this great panel discussion, and they answered a lot of questions about their application process in their states. Were there any highlights that or aha moments that anybody came out of that discussion with that you'd like to talk about? Was it helpful? Okay, so as you're thinking about that, maybe somebody's typing. A follow-up question to that is, would it be helpful to have a central location where states that do have an application process and an application in place, would it be helpful to have a central location where those applications can be kept so that others can access and be able to review and maybe adopt or adapt those applications? Lots of yeses, a couple of yeses in the chat for that. And my last question on the application process, are there any further questions? Do we need any more clarifications, or do you need help with the application process?
Julie, this is Cindy, and I'm not in a position to type, but yeah, my answer would be yes, but it would also be really helpful to have a dynamic spreadsheet that shows which states are where. There was one, it was blue and gray, I think, years ago. Because not only the application, but how frequently. And right now we're going in and clicking on a state and then clicking and clicking till we get to the detail of their description. And so I don't know what those 5 or 6 columns might look like, but by state, is it regulatory? Is it voluntary? How frequently they do it? How many levels they have were the ones that came to my mind. But I think that would also be helpful to be current and kept up to date and in one location.
Okay. Thank you.
Like, Dwayne has his hand up. Go ahead, Dwayne.
Go ahead, Dwayne.
So
Sorry,
the one thing I've encountered within my state, but I can consider I'm not alone, is once we're getting into the procedural component of this, it becomes very state specific, and I'm going to have to say the word governmental specific, if that's where the program is being hosted or funneled through. And I want to make sure that the application process we're talking about here is general enough that it doesn't put us into a pigeonhole that we can't meet it because of requirements or limitations that we're being challenged with within our own state function. We're all different, even as commonwealths and between Massachusetts, Pennsylvania, the term is a term. It doesn't meet function, work very differently, and I just want to make sure we don't put ourselves into a narrow cabinet that we can't work out of. The process itself is very different than developing a program, and I've actually put them on 2 separate activity logs in my process so that I'm working on them independently, and I'm getting the program developed and reviewed by one group of people, but the process for applying and verification and all that stuff is entirely different because it's impacted by and influenced by different parties.
Yeah, I have to absolutely agree with Dwayne. We're getting into regulation now, and in terms of each state or local authority associated with that. So I think the best that we can do is provide guidance, but not around the application for verification. It's just like trauma programs. It's just like, any other regulated program in the state. Some states don't have regulations, so it may provide you more flexibility, or it may be even more restrictive because you don't have regulation.
And so keep in mind that what we're talking about is a spreadsheet or a central location of examples, not regulation, not requirements, just here is what this state is doing, so that someone who wants to improve their process, they might want to see what another state is doing. Someone who's creating and just now developing their ED program or their process.
Yeah.
And to Dwayne's point, the program versus the application process versus the verification process, maybe they're working on a specific piece. They can go see what another state is doing.
Yeah, I think that's very helpful, but I think that but the way it was listed on the slide, it gives a totally different impression, so I mean, we're just, we're collecting data on the different types. So it's more like a survey of, or a compendium of, just seeing what people are doing. That's just a simple, data collection process. That's not recommendations. It's not guidance. It's not, yeah, it's different.
Right. Did I miss anything in the chat, Casey, that needs to be addressed?
No, I think you're good to move on.
Fantastic. Awesome. Thank you. So we'll start working on that. In the meantime, we have asked Sam Vance and Nicolena Mitchell to join us, similar to our conversation in April around the application process. Now we want to kind of hone in on the verification process. So thank you, Sam and Nicolena, for being here and being willing to answer some of our questions. So my first question for you is, I was hoping you would describe the process of when you designed yours. So think back to when you designed your verification process. Maybe speak to who was involved, if you have an ED and a pre-hospital program, maybe the differences in that. So just speaking to the design of your verification process. Nicolena, we'll have you go first.
Okay. Well, thanks for having me here today. So, and I apologize that my screen keeps moving. I'm in a very lovely facility, but they haven't officially opened it yet. So I'm sitting on the floor of an empty classroom, balancing my computer on my knee. So I apologize if the image looks like it's shaking. So Colorado, I was not there in a program manager role when Colorado first began developing its process. And I came in right as we were coming out of COVID. And we opted to try to engage several pilot hospitals for our pediatric hospital program. We do not have a pre-hospital program yet. So we engaged about 5 pilot sites who were willing to test the process for us. Rerunning our checklists, rerunning the criteria that we had. Was it feasible? Was it unfeasible? And then they were very kind with us, and helped us work through the pre-site visits. We didn't have pre-site visits before we started this verification process. The intention was they submitted the checklist to us, and then we would go out and do a site visit with them, planning about 3 hours to talk through their pediatric readiness work. We gave them a list of suggested people to bring to the table. The first site visit that we did, they brought in a lot of folks, and we realized that we should probably have a lot of questions based off of our checklist. And at that time, we just allowed them to present to us. This was them showing us the work that they had done. And since then, we just verified our 6th facility. And we have realized that we need to do a little bit more work on our verification process. So I am currently developing a spreadsheet that's going to look at specific questions that we want to answer when we are meeting together, things that we actually want to see, and any follow-up. Our goal and intention is that whenever we go to the site to actually do the visit, we're 99% sure that they're going to be verified. We want them to have done the work in advance, and we have found a potential issue where we are now going to be starting to ask our facilities who say, yes, we're ready for the verification process, to submit their policies to us in advance, so that we can take a look at them, offer them input, make sure that it is actually meeting the intention, and then moving forward from there. So now in the development of our process, it went from, we have a checklist that we ask them to fill out and an application, which is just a data collection of who they are, to a site visit. And now it is the application, the checklist, a pre-site visit where we talk about the resources that we're going to need in advance of coming to them, our expectations of them when we meet with them, what they hope to get from us. And then in the development of that, then we have an on-site visit with at least one, myself, and then virtual members. And then we are going to be reviewing all those materials after we get back, and then offering the verification or not. I think I might have gone down a little bit of a rabbit hole, Julie. So if I didn't quite answer your question correctly, feel free to correct me.
That's okay. You did answer the question. And brought up more questions for later. So thank you. Sam, how about for Texas?
Sure. Hi, everybody. First, I apologize. They're doing some work on my front door right behind me, so it's been very loud. Do you want me to go through the entire verification process, or just one specific area you want me to focus on right at the moment?
Let's talk about the process of how you designed it. Like when you first designed either one of the processes, because you have both ED and pre-hospital.
Yeah.
So let's step back in time and talk about who was involved in the design of the process. You sit down at the table and
Sure.
you say, here, we need a verification process. Maybe you already have an application process. What do we need to do? And how are we going to verify what we're asking you to do?
So with our ED verification process, we call that our voluntary pediatric recognition program, or our VPRP. That started many years ago with that process, and actually the second time around where we're at today started in 2014. We involved, as far as that subcommittee of our advisory committee that started the work on that, we had representatives obviously from our advisory committee, including fan reps. We had representatives from ENA, the Emergency Nurses Association, our Department of State Health Services, the Office of EMS and Trauma Systems. We had folks from our pediatric committee of our Governor's EMS Trauma Advisory Council, as well as representatives from several of the children's hospitals throughout the state. We designed the process off of the Pediatric Readiness and Emergency Department's joint policy statement. We use that to develop the program, and we started just really by gathering information, putting that information together. In 2014, I actually put together a informational booklet on recognition programs in emergency departments, using the states at the time that had their programs as a guide, and also using information from the first NPRP assessment to help guide in that process. So we took that information and started trying to get buy-in and sell it to the different organizations. So we did also have organizational representatives from Children's Hospital Association of Texas, as well as the Texas Pediatric Society, and many different organizations. So while we are not state-based, we're based out of Baylor College of Medicine in Houston, we still respect that regulatory process. So going through our Governor's EMS Trauma Advisory Council, taking it to the different committees to get their buy-in and their endorsement, and then we eventually took it to the actual council to get their endorsement of the program. And from there, that's when we actually started sitting down and developing our program. Was after we presented the idea and what we were wanting to accomplish, and sold all that, and that process all took a couple of years, and then that's when we actually sat down and started developing the actual process. Now on the EMS side, that was a little bit different. Sorry, I got a bug. With the EMS recognition program, that started in 2014 as well. And basically that was developed off of the program that I helped develop in Missouri back in 2009. So we essentially took the program from Missouri and just changed it up a little bit to meet our needs. The folks who were involved in that was similar to with the hospital side, folks from our advisory committee, including fan reps, EMS medical directors, EMS chiefs, the Department of State Health Services Office of EMS, and then more recently, our Air Medical and Specialty Transport Committee, when we did a revision recently. But yeah, we developed that with 3 different levels of verification of bronze, silver, and gold, and with gold obviously being the highest. And we developed that based off of the performance measures that were in place at that time. So having the pediatric equipment on the ambulances and having online and offline medical direction. So obviously, for the most part, we've met those performance measures. So we recently revised our program back in 2022 is when we revised it to meet the performance measures that were current regarding agencies having a PEC, having a process in place to do competencies, skills competencies once a year, and then also based on the current equipment list for ground ambulances that was published in 2020, I believe, as well as other aspects of the pre-hospital PEDS Ready project checklist. And then just this last year, we revised it again to include an air medical component to where we also now recognize our air medical providers.
Wow, that's a lot of improvement. Revisions, improvement.
Both documents are basically living documents, so we make those revisions as revisions are made to performance measures, revisions made from the national assessments, and so on.
I'm going to go back to Nicolena. You mentioned that you are on site for the 6 sites that have been verified, that you go on site, but that someone is virtual.
Well, yeah, so our goal is to have at least one member of our steering committee or our staff on site when we do the visit at that facility. Most frequently, that ends up being myself, and then we facilitate a Zoom session so that members of our steering committee can participate. And when we developed the steering committee, we tried to have a broad swath of hospital types represented, both from urban and critical access, everywhere in between. We have ENA representation. Our state has said that the Pediatric Readiness Program will not be regulatory. And so we work really closely with our trauma services section because they have a regulatory process and they do site visits. And so they were really important to us to guide us with like what has worked for them, what has not worked for them. We have troubleshot just, shared challenges. And so because we want that broad swath of participation from our steering committee, we try to make sure that every session has a Zoom link that is secure that our participants can join us in. And I think it's not only important for us to know that we have a wide variety of backgrounds represented, but we also want the site to see us and know that we are engaged with them and know that we really do want to know what's going on. We really do care. It was interesting. We invite our steering committee members from across the state. We reimburse their mileage. And if they need a meal or a hotel room, we cover that for, a limited number of people. But it's, I think, also really important for the staff who've completed the work to be seen. We had a site visit where it was led by the trauma team. It was very small, and you could tell they were working really hard to get the rest of the hospital on board. And they had 23 different members of their staff there, including CNO and CEO leadership, to hear about their work. And so we think of the site visits because we are doing the pre-work of the verification of policies and so on and so forth. We think of these site visits as their opportunity to shine, and to brag on themselves, not only to themselves, but to the members of their team as well. And then if it's possible, we do a walking tour of the ER because of the virtual component and HIPAA concerns. There's a lot of camera on, off, and I think we've made a couple of our members car sick just trying to watch the video as it moves through the ER. So the last visit we did not opt to do a Zoom session for the walking tour of the ER, but we get permission and we take lots of pictures because the other side is our members are learning from these hospitals. And so the pictures we're taking are usually of bulletin boards where they're talking about training frequency and who's been trained to do what, and the QI plans that are on the wall. We try to make sure that we are never intrusive to patient care. We went to one facility where a very sick patient rolled in and they said, nope, we're out. We're just going to go talk in the hallway. And that we were totally supportive of that. But we like to share the physical representation of pediatric readiness with our committee and our other members. And an example of that is many of our sites have printed, laminated, or QR code directions for syringe pumps attached to them. They train them manually. No one is allowed, obviously not allowed to use it if they've not been trained, but it's a low frequency use. And so the nursing staff said, it stresses me out every single time I have to use this thing because I'm not sure I'm doing it right. So they printed step-by-step instructions to remind them. One facility put in a QR code and put up a YouTube video that showed them the step-by-step instructions. And I think that's just an excellent representation of the pediatric readiness work. And we want them to be proud of that, but we also want to share those innovations. Patricia, your question about the average cost of site visits, it's kind of hard to say right now what our average is. I would say the most we've spent on a site visit is $250. And that included mileage across the state, a couple of meals in a hotel room, and some mileage for our committee members. There are some of our facilities that's going to require multiple nights at a hotel because you got to drive out the night before, do the site visit, and it's too far to come back the same day. So right now, I would say the high end is $250. The low end is probably around $50. You're on mute.
I was coughing, so I put myself on mute. So that was great state of Colorado. It's broad. Are you centrally located, or the steering committee team? Is it centrally located, or is it on one side? Okay.
No, it covers members from across the state. So the furthest west is almost in Utah. The furthest east member is in the Denver metro area. So we have members from all over the state. We lack on the eastern side because as COVID turnover hit, those facilities were hit really hard with turnover on the Eastern Plains. And so they have opted out. But all of our meetings have been conducted, all of our steering committee meetings to develop the process, to have our monthly meetings, to do our application review, that's still all by Zoom. And if you guys are contemplating putting together your steering committee, I would encourage you to sweep widely and with more members than you probably think you need, because we had a lot of people who say, I can't come this month. I can't participate anymore. And so we had a broad group, and now we're down to like a really solid core of 20 members. We still are trying to, recruit those things. And so, you know, I would encourage you to sweep wide, so that you have a sustaining membership.
So Sam, I'm going to ask you the same question. Another great state. I think it's the original great state of Texas. A little broader. So how does your verification work? Do you travel? Do you go on site? Do you do Zoom or virtual? I still think of Zoom because we're on Zoom.
Sure. No, so we, you know, with COVID, obviously it was all virtual. Post-COVID, we have done in person, but then we've also done a hybrid model where, because we are so spread out, some of us that are closer to the facility, we're able to go in person, some that were not, attended virtually. So we did a hybrid model. What we're currently looking at is possibly doing more virtual than in person, just because of costs. Presently, we're not charging any of the hospitals for the verification process, and we really are struggling with, you know, making that decision to charge them. However, we have discussed what we will probably do is if we do any type of in-person verification process, we will at least ask the facility to pay for our travel. So mileage, food, hotel, at least. Our state is so big that there's not very many places we can go in a day trip. So it's at least 1 to 2 nights that we're going to have to spend. I did see a question from Mark in the chat box that I'd like to address, because we did have one facility that they did do all of their pre-work for us, and we went ahead with the verification with the visit, and we did deny them. There were some components that they just didn't quite meet. We went over those components with them, those areas that they were deficient in, and we're going to schedule a follow-up with them. And for several different reasons, we have not done that follow-up, but we do need to do that follow-up soon.
Do you have a certain time frame that they have to do the follow-up in?
We don't have that outlined in writing. I believe we gave them 6 months to follow up, but there were some other factors that played into it to where we didn't do the follow-up in that 6-month period.
So Nicolena, have you asked the same of you? Have you had anybody that you've had to deny?
No, we haven't had anybody to deny, but when we went to one of our facilities, much like Sam had described, they checked everything off on the list. We felt pretty confident. We had some good, initial conversations, and we got there and we realized that their perception of what they were doing probably didn't meet the intention and the description of the various points in the checklist. And so we really struggled, and we were really glad that we went in person, because then we had that opportunity to provide them with some feedback about how to change their verification status, and that we opted then to, we did a little bit more work with them after the site visit and determined that we could verify them at the lower level. But if we hadn't been there in person, we wouldn't have had the opportunity to really identify these areas. And so, to Mark's question earlier, we have left the option open to ourselves to be able to do a 100% virtual site visit, because weather is a real issue in Colorado. We don't like to go make arrangements to do stuff in the winter over the passes, because it can get real dicey real fast. But so that's an option for us. I think that's also the nice piece about having a geographically diverse community that participates, because if I couldn't get to the Western Slope, I have a physician and nurse from a facility who we've already verified who could go in place of us to be that in-person source, and then help facilitate the Zoom session. So I will say, because this is voluntary and we are asking them to check themselves off, having that verification, I think, is important.
So we only have about 4 minutes left. So what I think we'll do is, if you're available and we can talk offline, we'll have you come back next month and we'll finish this conversation. We've got a few other questions, specifically, and for the group to think about. Those of you who have made it through the pilot phase, so you have your criteria, you have your application process, you have your verification process. Let's come back next month and think about putting those two together. So we have criteria. How do we verify those criteria? And then, so we're going to think about some of the more difficult pieces in person, and then some of the more difficult criteria to verify on virtually, and maybe share some ideas on those. Does that sound doable? Then I will hand it back over to Casey for some closing remarks. Thank you both, Nicolena and Sam, for answering our questions today.
Thank you.
And with our intention to hopefully have Sam and Nicolena back next month, if you do have any specific questions related to verification that maybe are on the top of your mind right now, if you put them in the chat or email them to me after the session, we can add those to our meeting next month to make sure that they're answered. Make sure if there are currently in the chat, we'll catch those. But again, if you have any additional questions, go ahead and put them there now or email me after the session and we'll bring those up next month. So with that, that is all we have for today. We do appreciate you being a part of today's discussion and continuing to be a part of this process. We appreciate your time and your commitment to the work that you do. And we look forward to seeing you again next month. Again, if you have any questions between now and then, feel free to reach out to Julie or myself and we'll help get that addressed. So thank you all and have a great day.
Thanks, everybody.